Dear students, warm greetings to everyone. I'm Tibor Hortobágyi, and I'm going to deliver a narrated version of the neuropathology lectures, which were originally delivered by Professor Béla Iványi 2 years ago in 2018. I'm going to spend a bit more time on explaining the pathological, in particular the neuropathological features of the organs and pictures demonstrated, and this is going to be helpful as a sort of replacement for the organ demonstration practices which cannot take place due to the pandemic. Also, the core knowledge of neuropathology this year going to be what is written on the slides, and you have also a separate PDF version uploaded on the website of this. However, I'm going to add some explanatory notes to the text as well, with the aim to help and facilitate better understanding or deeper knowledge, which may be useful for you in preparation for the exam, and also could be helpful for your future studies as a medical student in years to come, and later on as a doctor. So, pathology of the central nervous system, a little bit of wrap-up from anatomy, not too much, just the basics. The brain parenchyma is essentially composed of the following cell types, especially in normal conditions: neurons, different types of glial cells. I'm going to go into some details on that, and the teleal cells, cells of the choroid plexus. I like to emphasize that on pathological conditions, obviously you may have increased numbers of other cell types, including the inflammatory cells, for example, or neoplastic cells within the brain, and metastasis to brain with large numbers of foreign cells, i.e. cells originating outside of the central nervous system, could cause and impose a large problem, as we all know. If we investigate the brain and the types of the brain cells, histology is the basic method. As you know, hematoxylin and eosin stain, the blue and the red stain, is the basic. However, in neuropathology we apply sometimes other techniques, and one of them is the silver impregnation. And this silver impregnation, what you see on the slide, is the so-called Bilshowski silver impregnation, developed by a great German neuropathologist, which is very helpful to highlighting the axons and the dendrites, and also some pathological features not seen on this particular slide, but occurring in other type of pathologies. You can see also the neurons outlined, and there is some staining of the blood vessels as well, which is important to emphasize that what you see here is not pathology. You see, you have also some other types of stains. You do not need to know them for the exam, but if you are interested, you can learn that one of them is the so-called Bilshowski type silver impregnation. As we move on, I'd like to mention some of the astrocytic cell types. Astrocytes are found both in the gray matter and the white matter, and their cytoplasmic processes are very helpful to support the neurons. They are providing structural support, but they are also providing important functional support. For example, they have a buffering function also at the level of the synapses or in the neuropil, in buffering the levels of, for example, the glutamate, which is a very important neurotransmitter, and if it is occurring in high quantity, that could be toxic and induce apoptosis of different cells or even contribute to necrosis. The astrocytes are also important elements of the blood-brain barrier. The astrocytic food processes compose not only a structural but again also a functional element of the blood-brain barrier, abbreviated BBB. And astrocytes are the key cellular elements of forming scar within the brain. As you know, in peripheral tissues like in the skin, scar is usually formed by fibroblasts, and it is rich in collagen. It is not the case in the central nervous system, where astrocytes are forming the scars, which is much softer than the fibrotic scar, and is composed of the processes of the astrocytic cells, usually rich fibrillary processes of the astrocytes, which is separating, demarcating the damaged lesion, and also contributes to reparation. Oligodendroglial cells, as you know very well, they are located mainly in the white matter, and they are very important in forming the myelin sheaths of the axons. There are several diseases when myelination, myelin sheath formation, is the primary problem. These are called, as an umbrella term, demyelinating diseases, and multiple sclerosis is the best known of them. Next, I'd like to mention the ependymal cells, because the microglia is a bit of red herring in this listing. Ependyma is lining the ventricles, the ventricular system, and forming a barrier between the cerebrospinal fluid and the brain parenchyma. Microglial cells are of two possible origins. Some of the macrophages are developing within the brain in the embryo, and those are the resident macrophages which can be activated. And there is another population of macrophages which can be derived from the bone marrow, as it is noted here, and those macrophages are actually going to be transformed from monocytes. So as you know, the monocyte macrophage is a lineage. So monocytes are a possible origin of macrophages in the brain as well, and they become activated in encephalitis, and microglial cells play also a very important role in lesions where brain parenchyma is going to become necrotic, like in cerebral infarct. Just as a short note, it is important to mention that microglia is sort of a double-edged sword. And one way, it has a protective function. So microglia is usually in very close vicinity to damaged neurons. And recent research in past years has elucidated that in reversibly damaged neurons, the microglia is aiming to support and help the regeneration of those neurons. However, if the neuron has suffered an irreversible damage, the microglia is contributing to the usually apoptotic demise of those cells, and therefore removing those cells from the neuronal circuitries, which is a long-term relatively beneficial consequence of damage suffered by the neuron. So, if we use the good old hematoxylin eosin stains, then in the gray matter you see large number of neurons, especially the large pyramidal neurons are easily detectable. However, some of the small cells, they may represent glial cells, astrocytes, but on the other hand, it can be very difficult to differentiate these small cells, the astrocytes, from interneurons, which are the small cells of the cortex as well. And if we want to be sure which one is the astrocyte, which one is the interneuron, then we have to apply some special stain. For example, for astrocyte, the GFAP, the glial fibrillary acidic protein, or for interneurons, calbindin, for example, could be a useful marker to highlight them. And another cell population in the central nervous system, the adult neural stem cells. Obviously, in the embryo, there are loads of stem cells, which are important in the development of the brain, but some of the neuronal stem cell populations are surviving in so-called niches, N-I-C-H-E, in the niche is of the central nervous system, and they are in particularly relatively numerous in the dentate fascia of the hippocampus, and they have the potential capacity to generate or regenerate neurons, astrocytes, and oligodendroglial cells. Therefore, there are great expectations that these innate stem cell populations could perhaps one day be triggered and facilitated to replace those neurons which die during neurodegenerative condition like Alzheimer's disease. However, this is a very long way to go. And if we want to sum up, we can say that their exact role in health and disease is still not known. We know a lot, but not enough. So, what are the basic reactions of the central nervous system related to injury? There are some reactions of the neurons, of the glial cells, and the cerebral edema is the next to mention. If we talk about reactions to injury of neurons, it's always usually we start to mention the hypoxic ischemic injury. It's important to know the difference between hypoxia and ischemia. Hypoxia means low oxygen, and ischemia means low oxygen plus reduced blood flow, which is resulting in low level of glucose and ions and blood constituents as well. So neurons in general do not really tolerate oxygen deprivation for long. And there is another important concept of the central nervous system, that neurons have selective vulnerability to oxygen deprivation. Some neuronal cell population can survive for quite long, still in the magnitude of minutes, and the other neurons die much earlier, within a couple of minutes, and they turn into irreversibly damaged cells, and they are going to die by apoptosis or necrosis depending on the pathogenetic process. It's important that hypoxia and also the ischemia actually affect more prominently the large pyramidal neurons of the neocortex, of the hippocampus. You know, the CA, the cornu ammonis, the CA segment. The hippocampus has 4 CA segments, and those neurons, except the CA2, which is for some reason more resistant to hypoxia, ischemia, and other injuries. So the CA segment hippocampal pyramidal neurons are pretty vulnerable to ischemia and hypoxia, and so are the cerebellar Purkinje cells. So these are actually sensors of these hypoxic ischemic injuries. What do we see under the microscope in these conditions? So an early change is the so-called red neuron change. These indicate cells in the process of dying. You know, the road to death and demise. They become evident after 24, so between 12 and 24 hours after irreversible hypoxic ischemic injury. There is shrinkage of the cell body, so the overall cell size is decreasing. Pycnotic nuclei, it means the small nucleus staining very darkly with the hematoxylin if we apply this stain. Loss of the so-called Nissl substance, which is a characteristic feature of large pyramidal neurons, and there is intense eosinophilia, which means redness, of the cytoplasm, hence the name red neurons. If these red neurons die in a large quantity and in close vicinity, it may give rise to so-called laminar necrosis in the cortex. And this laminar necrosis usually affects layers 3 and layer 5 of the neocortex, because in these layers have these large pyramidal neurons their normal location. And there's another important aspect of hypoxic ischemic injury in the brain, which is not global but localized, the so-called border zone infarct. The border zone means that border zone of blood supply territories. In the hemisphere, in the brain, there are 3 major blood supply territories: arteria, the anterior, the middle, and the posterior cerebral artery. And in between these blood supply territories, in case of low perfusion or low oxygenation, these are the most deprived areas of the brain. For example, if someone is suffering or is in the way of becoming into cardiogenic shock, for example due to myocardial infarct, the perfusion pressure is going to decrease, the oxygenation in the lung is going to be impaired as well. Therefore, those neurons in the brain which are relatively close to the major branches of the major arteries, the anterior, middle, and posterior cerebral arteries, they are relatively well supplied with oxygen and glucose and other substituents. Whereas those which are really more remote from these major branches, they are suffering relatively So not relatively, but generally very poor oxygenation and glucose supply. Therefore, in these so-called distant regions of blood supply territories, which are actually the border regions of the blood supply territories of the major arteries, the so-called border zone infarct may develop, and they can be also visible grossly if the patient lives long enough, survives long enough. And this is an example on this picture where you have loads of red neurons undergoing necrosis in a laminar fashion. This is the typical appearance of the red neurons, and in many of them actually the nucleus is not only pycnotic, but actually there is also the so-called karyolysis has happened. So the complete lysis of the nucleic acid components of the nucleus, which is a sign of necrosis. The other feature what you can appreciate in this picture is the presence of these small vacuoles or bubbly-like structures within the neuropil, which is we call neuropil, the brain substance filling the space between the cellular elements of the neurons, and this is actually a feature of edema. Cerebral edema is again an accompanying feature of many of the hypoxic ischemic events because of the damage to the blood-brain barrier, and there's also damage obviously to the cellular membranes. Well, another possible feature and abnormality within the neurons is the presence of so-called inclusions, and these inclusions have various sizes and shapes and forms, and they are usually characteristic of certain neurodegenerative diseases like Alzheimer's disease or Parkinson's disease, and we are going to discuss them at those diseases and topics later on. So here is an example of a so-called Levy body in the substantia nigra. We know that this is from the substantia nigra because these dopaminergic neurons have these naturally brown pigmented small vesicles, which are actually dopamine containing small vesicles which are naturally brown, as mentioned, and within these dopaminergic neurons you see these very peculiar and very characteristic structures which are called the Levy bodies. They have a central eosinophilic core surrounded by a clear halo. We call it halo, which is surrounding it. And this is a typical Levy bodies. Some people call it Lewy body, but that's the same structure, which is characteristic of Parkinson's disease or dementia with Levy bodies, which is going to be discussed in a subsequent future lecture. And neuronal death sooner or later is occurring in these cells by apoptotic mechanisms, and in general the number of these dopaminergic neurons in this microscopic subfield what you see in the picture is less than it should be normal, so there is a neuronal loss also accompanying this problem. So, reactions of glial cells, that's the next topic. So, astrocytes and microglial cells. The astrocytes are responsible for the glial scar formation. It's very important. And the microglia macrophagic cells are important in phagocytosing lipids of the white matter, and lipids of the white matter are actually mainly the lipid material of the myelin sheaths. And if the myelin sheaths are degrading because of an infarction, for example, then these foamy macrophages, majority of them are actually coming from the circulation, i.e. they are monocyte-derived macrophages. They are phagocytose this lipid material, and on the paraffin-embedded material they appear as foamy macrophages. And foamy macrophages later on replaced by reactive astrocytes, forming gliosis and glial scar, which is consisting of the cytoplasmic processes of astrocytes, and as mentioned, there is no collagen in this event. So this is a piece of cerebellum. You can see some cerebellar cell types here down there, and high numbers of foamy macrophages and necrotic cerebellar brain parenchyma. So here are the foamy macrophages, what you see here. And if the examination of the brain occurs a bit later, so the patient survives longer, then at the edge this astrocytic scar formation is more visible, and actually the number of foamy macrophages after some time is going to be reduced, and after several months actually a cyst is going to remain after an infarcted lesion, which is characteristic. And if we have a closer look at these astrocytes, they are really have so more voluminous cytoplasm, very prominent cell processes. And if you apply the before mentioned stain GFAP, glial fibrillary acidic protein, then all these cells are going to show up with GFAP positivity, and that is a certain and that can reassure us that these cells are not of neuronal origin, which from the morphological point of view is a possible option. And microglia is also important in encephalitic processes. Encephalitis related to viruses, for example, or immune-mediated processes, or as paraneoplastic encephalitis. These microglial cells proliferate, they form aggregates around necrotic foci, necrotic neurons, and they phagocytose also the dying neurons, causing neuronophagia. And as you can see, these microglial cells, they appear in very close vicinity to these neurons. Here is one, there are two microglial cells just opposed to a neuron. I mentioned that in the reversible phase they are probably supportive. In the irreversible phase they are facilitating the death of the neurons and elimination of the neurons. And sometimes these microglial cells are forming these nodules. So this is a typical microglial nodule, which is an often seen feature of encephalitis. Sometimes you see in the neurons adjacent, so the not yet phagocytosed neurons, some inclusions, which could be viral inclusions, which can give a clue what is the cause of the encephalitis. For example, herpes encephalitis has quite characteristic cytoplasmic or nuclear inclusions. And HIV encephalitis, for example, has multiple multinucleated giant cells of microglial macrophagic origin. So if we have a closer look at these microglial nodules, we can have some ideas what was the etiologic factor or pathogenetic factor of that. The next topic is cerebral edema. It has two possible pathomechanisms: vasogenic edema, which is mainly located to the extracellular space, and we believe this is due to increased permeability of the blood-brain barrier. And in this process, the fluid escapes from the vessels into the interstitial space, localizing between the neurons and the glial cells. It is particularly frequent in inflammatory conditions and surrounding tumors, neoplasia, in rim-like manner. The other type of edema is the intracellular edema, which is having a cytotoxic mechanism due to hypoxic ischemic injury to neurons and glial cells, and this is very much related to the membrane dysfunction and impaired ion and water transport on the cell membrane. However, in many instances, vasogenic and cytotoxic mechanism act in parallel, occurring both. So the cytotoxic is believed to be very frequent to hypoxic ischemic injury, but in an ischemic stroke, both mechanism, the vasogenic and the cytotoxic, is important and relevant. So the brain edema can be focal and diffuse. The focal is usually related to a mass lesion like tumor, hemorrhage, abscess, or infarction, and the edema is usually surrounding these lesions, whereas the diffuse brain edema is related to several other conditions, and one of the important reasons are the global hypoxia, which may have several reasons and causes like anemia, carbon monoxide poisoning, cyanide poisoning, lung diseases when the CO2 oxygen exchange is impaired, and the list of lung diseases range from pulmonary edema, bronchopneumonia, to interstitial lung diseases, and so on, as it has been lectured in the pulmonary pathology lectures. So the morphology of diffuse brain edema, one macroscopic feature is the increased brain weight, which is normally around 1300-1315 grams. It is also softer than normal on touching, on palpation, and is very characteristic to have flattened, broad gyri and narrow slit-like sulci. So this is a very characteristic neuropathologic features, and as a consequence of the swelling of the brain, the lateral ventricles are going to become compressed. This is a sign also visible on imaging like CT and MRI, and on sectioning, the fluid sweeps from the cut surfaces, and also blood and blood constituents are easily visible on the cut section. And there could be signs of herniation, which include the tonsillar herniation, but there are also several other types of herniation which we are going to discuss as next in a couple of slides time. So the diffuse brain edema can be seen on imaging, and as you see, the lateral ventricles are really slit-like. The sulci between the gyri are really very, very thin, usually invisible, and the overall characteristic with the really scanty liquor spaces. The CSF spaces are not only invisible within the brain, but also the subarachnoid extraventricular liquor spaces becoming actually undetectable or hardly detectable in these cases. And the increased intracranial pressure is then leading to herniation. And the problem with the skull, that the skull is a closed box. It cannot really expand unless the patient is very young, before the ossification of the fontanelles occurs early in childhood. And therefore, if the brain parenchyma is swelling, it is going to compress the brain parenchyma against the bony structures, which is actually the morphological basis of herniation. Papilledema, which can be examined by ophthalmological methods, looking down the fundus of the bulbs, is again a characteristic feature, and is a consequence of the swelling of the optic nerve head. Patients with increased intracranial pressure have characteristically nausea, vomiting, headache, and later on there is impaired level of consciousness. The GCS, the Glasgow Coma Scale, is decreasing from the normal value of 15 downwards, and the patient at the end may die from the coma. It's very important to treat cerebral edema. There are various ways doing so, which are going to be discussed in the clinical specialties later on. And now we are going to focus some aspects of the herniation. So there are three major types of herniation. One is the underneath of the falx of the cerebrum, the subfalcine herniation, when the cingulate gyrus is going to become herniated. So the next one is the so-called transtentorial, when underneath the free edge of the cerebellar tentorium, usually the uncus of the parahippocampal gyrus is going to be herniated through, and there is the herniation into the foramen magnum of the cerebellar tonsils, which is called tonsillar herniation or cerebellar herniation. So here you see the subfalcine herniation, when a unilateral mass in the brain, in this hemisphere, is going to cause actually a little bit of midline shift, and this is the cingulate gyrus, which is going to be compressed against and onto the other side of the brain, to the other side of the brain, causing necrosis and hemorrhage in this area. This is the subfalcine or cingulate gyrus herniation. And this may also cause compression of the anterior cerebral artery, which is running just above the corpus callosum, leading to anterior cerebral artery or ACA, tertiary brain infarcts, which characteristically affects the superior frontal gyrus as well. The next one is the so-called transtentorial herniation, when the uncal gyrus of the hippocampus is compressed against and through the cerebellar tentorium, and actually this herniation is often forcing then the cerebellum to push into the foramen magnum. So this is one possible mechanism of supratentorial compartment space occupation causing tentorial herniation. And this is also important that once this uncal herniation occurs, then the third cranial nerve, the oculomotor nerve, can be compressed against the bony structures, and that is the result of the fixed pupil on that side. And this further explains this what I have already mentioned. Ipsilateral fixed pupil can occur in this case of herniation, and this is a very basic part of the neurological examination of a patient when we are searching for usually unilateral space occupying lesion within the cerebrum or the cerebellum. The posterior cerebral artery can be compressed as well, which is leading to necrosis in the blood supply territory of the posterior cerebral artery, which also includes the primary visual cortex, the calcarine and pericalcarine areas, and there is this occipital or cortical blindness may happen, which is associated, if unilateral, with visual field defects. And the compression of the cerebral peduncle results in upper motor neuron signs and the brainstem compression, because here in this area you see the reticular formation with the centers for regulation of cardiorespiratory function, may cause quite quickly the death of the patient. The tonsillar herniation is when the cerebellar tonsils are forced into the foramen magnum, and this is causing compression again those respiratory and cardiac centers within the medulla, and the reticular formation causing death of the patient. This is a well-known complication of this. And here is a macroscopic image of a patient who died because of these problems. You see the deep impression of the cerebellar tonsil with some necrotic features against the foramen magnum, and this necrotic lesion is also important for the neuropathological verification of cerebellar tonsillar herniation. As a secondary consequence of space occupying lesion, especially in the supratentorial compartment, is the so-called secondary hemorrhages in the pons, which are called Duré hemorrhages. This is a French person's name, Duré hemorrhages, which are usually resulting in these striped hemorrhages or these flame-shaped hemorrhages, which distinguishes these hemorrhages which are secondary to space occupation in the supratentorial compartment from the primary pontine hemorrhages, which may happen not so infrequently in hypertension. So that's another problem what may well happen. So, and the next topic to cover is hydrocephalus. As we know, hydrocephalus results in excessive production of cerebrospinal fluid, or CSF, or decreased resorption of the cerebrospinal fluid through the arachnoid granulations. The CSF is produced by the choroid plexus, then it circulates through the ventricular system and leaves the ventricular system at the foramina lusca and majandi, entering the cisterna magna, which is a anatomical space containing cerebrospinal fluid. And whether the production is increased or the resorption is decreased or the flow itself is impaired, all these lesions can lead to hydrocephalus, primary hydrocephalus, because later on we are going to discuss the secondary hydrocephalus as well. In primary hydrocephalus, there is accumulation of CSF accompanied by an increased intracranial pressure and increased CSF pressure. This is important to distinguish it from the secondary hydrocephalus, which what will be discussed later on. It can be congenital or due to acquired obstruction of the CSF flow, so the congenital obstruction or acquired obstruction of the CSF flow, and these obstruction can be caused by different lesions. Any anatomical site of the ventricular system and the CSF flow can be impaired, and the usual suspects are neoplasms, intracranial or intraventricular neoplasms, or organized blood or inflammatory exudate obstructing the foramina, and these are usually these organized subarachnoid blood or inflammatory exudate on the base of the brain, which then cause the obstruction of the foramina Luschka and Majandi, resulting in accumulation of the CSF, which is still going to be produced by the choroid plexus but cannot get into the external CSF space, cannot get into the arachnoid granulation, which are responsible for the resorption. Sometimes it is not so frequent. The arachnoid granulation can be impaired by inflammatory exudate hemorrhage, which then leads to the impairment of the resorption of the CSF, another cause of hydrocephalus. When hydrocephalus develops before the closure of the cranial sutures in young children, there is a massive enlargement of the head, and this young child body prepared for presentation, and in this anatomical museum here in Szeged you can find it. You see this massive dilatation of the head with hydrocephalus. Fortunately, in these days you are not supposed to see such a severe case of hydrocephalus, because the evolution of this hydrocephalus can be prevented by so-called shunting, so insertion of a shunt, a so-called ventriculoperitoneal shunt, which is draining. Here you can see hydrocephalus can be treated by insertion of a ventricular shunt with a one-way valve system to drain CSF into the peritoneum. And this plastic tube is then led from the skull down underneath the skin, down to the peritoneal cavity, and from the peritoneum the CSF is actually can be resorbed. And when the hydrocephalus develops after fusion of the sutures, it is associated with intracranial pressure increase, expansion of the ventricles, and pressure atrophy of the brain. And here is a characteristic feature of this pressure atrophy of the brain: the hugely dilated ventricular system, including the third ventricle and the aqueduct, and especially the white matter, but to some extent also the great matter, is very, very atrophic, and the ventricular system is hugely dilated in a very severe case of hydrocephalus. And finally, we have got to the so-called secondary or compensatory hydrocephalus, which is actually not a consequence of the increased CSF pressure within the ventricular system, but as a consequence of the lost brain parenchyma. And a very frequent cause of loss of brain parenchyma, especially in the elderly population, in particular those who suffer from dementia, is the loss of neurons, and then the dying neurons, axons, are also going to degenerate. The myelin is going to become decomposed, phagocytosed by the old macrophages, and actually there is going to be a great reduction of not only of the gray but also of the white matter, and there is a compensatory dilatation of the ventricular system, which is called hydrocephalus evacuo as well, with the traditional Latin terminology. It's important that the intracranial pressure is normal. So this brain is from a patient who probably suffered from Alzheimer's disease, because the hippocampus, both sides, is very, very small. There is a wide spacing at the lateral or at the inferior or temporal horn of the lateral ventricle. Here the lateral ventricle is also heavily dilated, and the third ventricle as well. And as you see that the gyri is pretty narrow, the sulci are widened as a sign of cerebral atrophy. The sylvian fissure is also widened. Here is the insular cortex. Here you see the putamen and the pallidum, which is of relatively normal size, typical feature of Alzheimer's disease type neurodegeneration. The next topic is brain injury or CNS trauma, which frequent problem and may manifest it as concussion, contusion and laceration, diffuse axonal injury, traumatic intracranial hemorrhage, and spinal cord injury. These are the most frequent and major types of CNS trauma. There are also some less frequent or so there are different other trauma types which are beyond the scope of year 3 neuropathology teaching. So the concussion is a clinical syndrome brought about by closed head injury, characterized by sudden onset and transient neurological dysfunction, loss of consciousness, respiratory arrest, and loss of reflexes. It is typically associated with the axonal injury in the white matter, and recovery is usually complete. However, amnesia, loss of memory to the events is a quite frequent and typical feature. The contusion or bruising of the surface of the brain is a more frequent is a more severe type of traumatic injury, where there is a hemorrhagic necrosis of the superficial cortex at different depths, which is actually the basis of the grading of the severity of contusion from the morphological neuropathological point of view. Obviously, another aspect is the extent of the contusion regarding the neuroanatomical localizations. So this results from rapid deceleration or acceleration of the skull and brain, and this involves two typical injury sites, the so-called coup and the contra-coup lesion. These are French words indicating the damage at the site of the injury and on the contralateral slide, as I'm going to show it on the next slide, on the next picture. It can be associated with laceration, which is again a severe type of traumatic brain injury, more severe than the concussion, what we discussed at the previous slide, when there is also tearing of the brain tissue resulting in disruption of the blood vessels, causing intracerebral hemorrhage. In this type of severe injury, there is often skull fracture detectable, and it may have several consequences. If the skull fracture is affecting the base of the skull, then some CSF fluid may, the leakage of the CSF fluid may happen, and through the nose, some CSF may be released. And if the skull fracture is also affecting blood vessels, then epidural hemorrhage may occur, as we are going to discuss it a bit later. So the outcome may be healing with gliosis. If extensive, it may be lethal, and as nearly any type of traumatic brain injury, as a long-term consequence, it may be associated with epilepsy. And often quite severe epilepsy. So here is the image which shows you the so-called coup and the contra-coup in contusion. So this is the site of injury, the lateral side of the brain of the cortex, and the underlying matter has been heavily damaged with necrotic lesions, hemorrhage. There is also some edema and swelling of the brain. Subarachnoidal space is filled with blood. So this is the site of the injury. So from this side, an impact has been exerted on the brain parenchyma, and here is the so-called contra-coup, which is much less severe, and this is the result of the movement of the brain within the skull, because it was hit from this side and it was pushed against the other side of the skull, and during this physical movement of the brain, some extent of contra-coup lesion has also developed with some subarachnoid hemorrhage, and if you compare the two, this is much less severe than the other one. Here is the splenium of the corpus callosum, and some other structures of the brain. So what may happen in these lesions when there is rotational acceleration and deceleration of the skull? The so-called diffuse axonal injury, DAI, may happen, and the DAI could be of traumatic origin. So there are some other causes which may cause diffuse axonal injury, which we are not going to discuss today. And this results in axonal damage. And the axonal damage can be visualized classically by means of silver impregnation, as you can see here, but nowadays we have also more reliable and better methods, and the axonal damage is a result of the shearing, traction and compression of the axons, where it can cause some thickening and swelling of the axons, which is as said, if it is very severe, it is detectable by silver impregnation. However, in these days there is a much more frequently used and reliable method, and you do not see this slide in the PDF which was uploaded to the website. This is from my personal collection and I added to it. When you use APP, which means amyloid precursor protein immunohistochemistry. The APP is actually a protein which is relevant to Alzheimer's disease, because this precursor protein is the precursor of the beta amyloid, one of the pathological proteins in Alzheimer's disease. And the reason why it is also suitable for detecting traumatic axonal injury is that APP, which is produced in the cell body, is going to be transported downwards towards the synapse through the axon. So the axonal transport is a typical mechanism of movement of APP from the cell body to the synapses. And if the axon is disrupted, for example due to traumatic injury, then the APP, which is transporting down at a relatively high speed, is going to accumulate proximal to the injury site, and they are going to form these axonal bulbs and accumulated protein materials, which can be detected by means of immunohistochemistry in the white matter, for example, and this shows clear evidence of traumatic axonal damage. And these axonal swellings and focal hemorrhages may also occur. I did not mention that, but in more severe cases of these type of injury, not only the axons are becoming torn and twisted, but also the small blood vessels, and if they rupture, they cause small focal hemorrhages. And these focal hemorrhages has some very characteristic neuroanatomical locations, usually in the paraventricular white matter. It may happen also in the cerebellar peduncles, for example, in the some of the deeper white matter structures as well. And clinically, the patients having suffered diffuse traumatic axonal injury may become comatose, instantaneous deep coma. They are usually suffering a fatal brain damage, and the survivors are usually living with quite severe neurological deficit. So this is a quite important type of traumatic brain injury, and this is an example of a traumatic brain injury which neither macroscopically with the naked eye nor under the microscope has very severe and striking appearances. So you really have to examine the brain quite meticulously, use those APP immunohistochemistry methods to be able to detect those axonal damages and establish the cause of death in these cases. It has high relevance in the forensic neuropathology practice, when the question is whether the patient died of this traumatic brain injury, which can be related to road traffic accident or criminal activity or not. So the next topic to discuss is the traumatic intracranial hemorrhage. Intracranial, it means that different compartments of the intracranial compartment can be the site of the hemorrhage, and as said, hemorrhage is a frequent complication and component of CNS trauma, and the hemorrhage can occur in the epidural, in the subdural, in the subarachnoid space, or in the brain parenchyma. So actually in all possible compartments of the brain, traumatic hemorrhage may occur. Importantly, without neurosurgical intervention, death occurs in a significant number of patients in cases where the amount of accumulating blood is significant, because the accumulating blood is causing extra volume and extra pressure within the brain and within the intracranial cavity. It is going to cause increased intracranial pressure, and increased intracranial pressure is leading to herniations, for example, or compression of the brain, which has high mortality rate. So, if we talk about epidural bleeding, it's also important to recap a little bit of anatomy. The middle meningeal artery, this here is the middle meningeal artery, here in the other side. It runs between the dura mater and the skull. And if there is a skull fracture affecting the temporal bone, there is also usually tearing and dissection of the middle meningeal artery, which is going to cause a quite rapidly evolving arterial bleeding and then epidural hematoma. And if we do imaging, then you can see here in the right hemisphere developing epidural hematoma, and some of the imaging techniques is enabling also to reconstruct the skull and finding the source and type of the hemorrhage. As mentioned, temporal bone fracture causes rupture of the middle meningeal artery, accumulation of arterial blood between the dura and the skull, causing increased intracranial pressure and death. The lucid interval means that following the injury and the fracture for some time, but not really very long time, the patient is still conscious. But as the blood is accumulating and the intracranial pressure is increasing, then the GCS, the Glasgow Coma Scale, is starting to drop, and the patient is going to get into unconscious state. And unless this bleeding is evacuated or stopped by means of usually neurosurgical interventions, the patient has a very high risk of mortality. So this was the epidural bleeding, and now we move to the subdural bleeding. In the epidural bleeding setting, we have to talk about the middle meningeal artery. In the subdural bleeding, the typical suspects and the culprits for the as source of bleeding is the so-called bridging veins, and the bridging veins are small veins connecting the dura and the arachnoid membranes. If you Google bridging veins and click on pictures, then you are going to see several very nice examples of anatomical sketches to show how these bridging veins are connecting the dura and the arachnoid membrane. And you can then understand quite clearly that if there is a movement of the brain, these connective veins can be torn, and this could be a source of a venous hemorrhage. And the subdural hematoma, as opposed to the epidural hematoma, is usually evolving relatively slowly, because this is a venous hemorrhage. And sometimes the patient is going to have the first symptoms after a very long lucid interval. Usually, it takes several hours, maybe the day after the head injury, which is quite often a so-called blunt head injury. It is not a very severe head injury. It is not associated with fracture of the bone. And the typical patient is an elderly patient, usually with dementia, and this is accompanied by a small brain and atrophic brain. And the atrophic brain, upon a blunt head injury, has a more space to move. So the smaller brain is not really filling the skull as well as in a healthy person. Therefore, there is more space for movement of the brain within the skull, and there is higher chances of disruption of these bridging veins, which then can be a source of accumulating subdural hematoma. And the subdural hematoma again is causing, for example, heel midline shift, a quite severe right to left midline shift, which can be visible. Here is the midline pressed against to the other side. There is the lateral ventricles are in this side, the right side invisible, on the other side is really slit-like. So and this hematoma can also be evacuated or removed by neurosurgical interventions, which could be life-saving. Sometimes these subdural hematomas are acute, quite rapidly increasing and causing increase in the intracranial pressure, although the pace of the accumulation of the blood is always slower than in case of an arterial hemorrhage, like in the epidural hematoma discussed before this. And the chronic epidural hematoma sometimes is evolving very, very slowly. It may cause change in personality, in memory loss, so it may cause memory loss, some confusion, and is quite typical in elderly and alcoholics. These chronic subdural hematomas sometimes may rebleed because they can become organized, but after some time, for example, when the patient is receiving anticoagulants due to atrial fibrillation or other causes, then there could be a rebleed on this chronic subdural hematoma, and there is going to be the so-called an acute on chronic subdural hematoma. So the size is going to expand and the symptoms and the problems are going to aggravate with this so-called acute on chronic subdural hematoma. And next we are going to discuss the subarachnoidal hemorrhage related to trauma. And this can be related to rupture of the arteries of the circle of Willis, which cause rapid accumulation of arterial blood in the subarachnoid space. Never forget that the most frequent cause of subarachnoidal hemorrhage is the rupture of the so-called berry aneurysm of the arteries of the circle of Willis, and that is usually not related to trauma. So traumatic subarachnoid hemorrhage is less frequent than subarachnoid hemorrhage due to rupture of the berry aneurysm. It is causing meningeal irritation, rapid increase in the intracranial pressure because this is an arterial bleeding, and it needs urgent medical neurosurgical intervention to save the life of the patient. The next possibility, when the patient suffers an intraparenchymal hemorrhage related to trauma, and this can be related to rupture of small intrinsic vessels in the setting of brain trauma with contusions and lacerations, which we have already discussed, and this results in increased intracranial pressure, focal neurological deficit depending on the localization of this lesion, and it can be fatal, especially if the anatomical localization and the size and the volume of the hematoma is significant. So what can be the outcome of CNS trauma? In minor head injury, usually there is a satisfactory recovery. It can be a full recovery, but there could be some late consequences of even repetitive, relatively minor head injury, as we are going to discuss later. If the head injury is severe, the recovery can be good, but there is a chance that the patients remain disabled. And these are the typical complications which may ensue. So one is the post-traumatic epilepsy, because these CNS traumatic lesions are actually going to heal with glial scars, and these glial scars act as epileptogenic foci. And many of these patients are having sometimes even pharmacologically uncontrollable epilepsy. Post-traumatic hydrocephalus may happen, for example, if subarachnoid hemorrhage is becoming organized, and this is interrupting the normal CSF flow. This organized subarachnoid hemorrhage can affect the flow between the intraventricular and extracerebellar CSF spaces, so obstructing the Majandi and Luschka foramina. Or the other problem when the arachnoid granulations are going to be affected by the subarachnoid hemorrhage, causing disturbed CSF resorption. The post-traumatic dementia is the other thing which may be also related to the repetitive, relatively minor head injury. And this has been researched and investigated quite a lot in the past years. And the so-called CTE, chronic traumatic encephalopathy, CTE, is an entity which is heavily investigated in these days, and this is usually quite frequent in in boxers, for example, or American football player, or even the usual British English football players as well, when repeated head trauma during several years are initiating sequence of events which lead to dementia or also movement disorders like Parkinsonian symptoms. And if the head injury is very severe, persistent vegetative state may occur, which is quite frequent in patients with very severe diffuse axonal injury. Another type of neurotrauma is the spinal cord injury. So, as we know, it is happening unfortunately quite often to young people. The usual victims are motorbike riders who suffer accident, and the mechanism is in many cases fracture and dislocation of the vertebra, causing contusion, nerve fiber transection, hemorrhagic necrosis of the spinal cord. And lesions involving the thoracic vertebra or below lead to paraplegia, and paralysis of the lower extremities, whereas cervical lesions result in tetraplegia. It is worth noting that lesions below the C5, cervical 5 segment, are usually compatible with life, whereas lesions at C4 or above are usually causing also impairment of the innervation of the diaphragm and respiratory muscles. Therefore, those are usually lethal. So therefore the C5 level is an important anatomical site regarding the prognosis. The consequences are not only the movement problems, the paraplegia and the tetraplegia, but also incontinence and urinary tract and pulmonary infections, and all the consequences of bedridden state and chronic conditions with pressure sores and muscle wasting. And this is the end of this first neuropathology lecture.